Good morning, everyone, and thank you for joining us for another training, which is being facilitated by PAHO on behalf of the PANCAP CVC COIN Multi-Country Global Fund Project. My name is Sandra Jones, Technical Advisor with the Pan American Health Organization, the Sub-Regional Office, which is based in Barbados. I will be chairing the training I will be chairing the session this morning, which focused on innovating the HIV Combination Prevention Toolbox with pre-exposure prophylaxis and non-occupational post-exposure. The activities which are implemented by PAHO under the PANCAP component of the grant, as I had explained during the last training, builds on key activities which were completed under the past Global Fund project and aims to scale up and to advance the implementation of sustained evidence-based interventions for key populations in the Caribbean. As a result, the training that we are currently implementing at the end should support the realization and the full implementation or the strengthening of HIV/STI services for key populations in the Caribbean. I will now look quickly at the objectives that we have for the training for today. The learning objectives for the training are to increase knowledge of participants in the clinical management of PrEP and the delivery of PrEP services, to provide participants with an overview of the most recent WHO recommendations on PrEP and nPEP, new scientific evidence and implementation data emerging from field, and of course to present current WHO guidance on PrEP programming and provide a space for participants to share experiences among countries and prepare for nPEP implementation or scale up in the near future. Just a quick prior to the training, we had circulated a link for participants were encouraged to take the JPIGL WHO course on the clinical management of PrEP before this session. We hope that I realized that some individuals had some issues accessing the site. We hope that you were able to, or if you were not able to access the site to do the course, you'll be able to do so following the training. These training will soon be available on the PAHO virtual campus, and we will also be sharing the link to the site as well. Quick housekeeping announcement before we get into the agenda which was shared earlier. Your mics are muted, and during the discussion period, they will be opened to facilitate the session following the presentations. So that to ask a question, kindly press the raise hand icon, which I think is next to your name. The mic will be opened for you to speak. The training is being recorded, and the link will be shared by PANCAP. It will also be uploaded to the PANCAP and the PAHO website, as well as other social media platforms for the benefit of persons who could not have attended this live session. So with these logistics covered, I will now move to the agenda item. The agenda is up on the screen, and we will ask for Dr. Rosman Adams, the Director of PANCAP Coordinating Unit, to make some very brief remarks. Dr. Adams, welcome, and I turn the mic over to you.
Good morning, Sandra. Thank you very much for that, and good morning to everyone. Let me first of all say thanks to all the participants for participating in today's virtual training. Special thanks to PAHO, especially to Sandra for leading and coordinating on these activities. As Sandra mentioned, they are not standalone and they are not new activities. They are a continuation in the whole continuum of work that we're doing under the PANCAP CVC Global Fund grant to support care and to support services with a focus on really reaching the key population. I would also like to say thanks to Giovanni, who have always made himself available to share new information and to provide technical guidance and support to strengthen the HIV-STI epidemic response to the region. Also, special thanks to the WHO colleague who is also going to present today, and to Anton, Dr. Bess, who is also going to present the experience from Barbados. As we know, we are confronting a global pandemic, COVID-19, and we know that the disruptions that this have had on the progress of the HIV response across the region. Not only are programs impacted across the region, but lives are also impacted, and so we really have to look and see how we can look beyond these disruptions and to seize, the opportunity for us to examine systems and to implement, to fix, to try out new approaches, whether it is through piloting or whether it is through demonstration projects. When we look across the region, HIV prevention services, testing, key population services are the most impacted by COVID-19. And so instead of us really looking at, the disruptions and the setback that we're being faced by COVID-19, I think that it is a perfect opportunity for us to see how well we can integrate HIV services, how best we can scale up, and how best we can implement and expand interventions that are indicated in the WHO, UNAIDS HIV Combination Prevention Framework, focusing on really looking at having high impact outcomes during the COVID pandemic, and even beyond that. We know that this is a very important topic in the region. We've been discussing the issue of PrEP and nPEP for a while, and so I think it is really time for us to move forward. It is time for us to use the evidence that is available. It is time for us to hear from the experiences of countries that are at different stages in the implementation process, and to look for avenues to say, well, these are gaps that have really been highlighted, and these are gaps that are showing up because of COVID-19, and let us seize the opportunity to insert these interventions into these gaps so that we are able to ensure the continuity of care, and we're able to also, support combination prevention programs in the region. There are numerous gaps from the policy level to the providers level to the users, but with these types of training that we're doing, we're hoping that we can provide you, civil society, national programs, providers with the knowledge and with the skills, so that we're able to advocate for, we're able to use, and we're able to encourage the use of PrEP. We're able to implement these tools so that we're able to move forward in a quicker manner to end the AIDS epidemic in the region. We know the fight is ongoing. It is going to be continuous. The challenges lie ahead of us. We are confronted by challenges currently, but let us look to see how we can use these available resources that are at hand to really push for these interventions, and to see how best we can have them inserted and utilized, and ensure that we're getting suitable results and outcome to really improve and to push the needle forward as we progress towards 1990 and beyond, the SDGs and so forth. So again, let me say thank you to the organizers. Thanks to Sandra, Giovanni, and all the participants who are here. And we look forward to an enlightening session today, especially hearing from the experience of Barbados, the assessment of the PrEP implementation from Dr. Bess, and also to get feedback from other countries and other participants in terms of challenges, successes that you may have, and support and technical support that you may require, so that we can see how we can support you along the way. Thank you very much, Sandra. Over back to you.
Thank you very much, Dr. Rosman. And with no further delay, and in order for us to have enough time for the presentations and for discussions which are very critical to this training, I now hand over to Giovanni Ravasi, the Care and Treatment Advisor with PAHO based in Washington, and he will take us through the first presentation, which will look at the overview of WHO guidance and implementation of tools for PrEP and nPEP. Go ahead, Giovanni, over to you.
Thank you so much, Sandra. I hope anyone can hear me. So I will really do a brief overview to kind of set the scene for this session with the WHO recommendations on pre-exposure prophylaxis and non-occupational post-exposure prophylaxis, showing some available tools from PAHO, WHO, and partners, and the PrEP implementation, the status of PrEP implementation in Latin America and the Caribbean. So in this slide, you can see that there's a favorable trend in the reduction of new HIV infections in the Caribbean between 2010 and 2019. But if we think that the commitment and the milestone is a 75% reduction, there's still a way to go to make sure that we really are on track to end AIDS by 2030. So there's more work to do in HIV combination prevention, even though I think this is an important success to acknowledge. But when we look at the characterization of new HIV infections in the Caribbean by population group, then we can see that is really a variety of populations, and up to 60% are key populations and their partners, with different challenges, different needs, and different preferences. So when we shape combination prevention strategies, we should also think that they should offer the whole range of options, including, of course, the ones that we know that are of high impact by the evidence that is being generated in the last few years. And this includes, of course, pre-exposure prophylaxis. So pre-exposure prophylaxis is not new, and it's not a new recommendations. The implementation of demonstration projects for PrEP is supported by WHO since 2012, but it became a strong recommendations for men who have sex with men in 2014, and finally a recommendation for persons with substantial risk of HIV, regardless of the population group, in 2015. And since 2017, WHO has been focusing on implementation tools and aids and guidances that have the objective of facilitating country policy uptake and implementation at the country level. And this includes the 2017 implementation toolkit, the inclusion of PrEP medicines in the essential medicines list, and as Sandra mentioned, an online training tool, but also a PrEP app with access directly to the PrEP guidances, and some specific updates on event-driven PrEP and PrEP and STIs, as Yanis will mention after this presentation. So it's important to say that the recommendation on PrEP in 2015 was a strong recommendation based on high quality of evidence from randomized clinical trials and other observational trials. And it's important to stress three aspects. is not a standalone intervention, is an additional prevention choice within the options of combination prevention, and is specifically for people at substantial risk. So in that sense, PrEP should be offered and combined with other traditional prevention interventions such as condoms and lubricant distributions, the STI screening and management, HIV testing and counseling, HIV, STI risk reduction and management, and harm reduction for persons who use drugs. And it's also an opportunity to provide comprehensive services. It's not just delivering the pill, but services should provide adequate adherence counseling, legal and social support, psychosocial support, mental health, and PrEP is really should really be seen as part of comprehensive sexual and reproductive health. And of course, thinking that we are targeting people at substantial risk in many settings belonging to vulnerable groups, then combination prevention services, including PEP and PrEP and nPEP, are an opportunity to keep these persons linked to care. So when we define substantial risk at a population level, WHO is suggesting an incidence rate of more than 3 cases per 100-person year, referring to either geographical areas or specific population groups. But at an individual level, we really need to use some criteria that translate the increased risk of exposure to HIV. And this can be, as you can see in this slide, summarized in HIV negative and sexual partner with a person with HIV who is not vitally suppressed, and these are the serodiscordant couple, reminding everyone that U is equal U. So if there's a vital suppression on treatment, then there's no risk of HIV transmission. But also HIV negative and sexually active in a high HIV incidence prevalence population, and any of the following criteria: vaginal or anal sexual intercourse without condom with more than one partner, or a sexual partner with HIV risk factors, or a history of sexually transmitted infections, or the use of post-exposure prophylaxis, this in the last 6 months. But we should also consider people requesting PrEP. People may not fall into one of the previous criteria, but they know that are going to be exposed. So persons that are coming to our services requesting PrEP because they're expecting to be at risk in the future should also be included. So again, there are different tools to facilitate the screening for PrEP eligibility. But in this slide, I just want to stress the fact that in the previous one, we saw that the use of PEP, and in this case we're referring to non-occupational PEP, so a post-exposure prophylaxis following a consensual sex exposure to a risk of HIV infection. So there's a PEP to PrEP approach, but during the PrEP eligibility procedure, we might identify a person that had a very recent exposure to the risk of HIV infection in the last 3 days. And this is a great opportunity to offer non-occupational PEP. So the message is PrEP and nPEP are very much part of the same HIV combination prevention package, and we would encourage countries and services to make sure that they're offering both of them. And again, we said it's not just about the pill, and it's not just about HIV, but offering PrEP is part of a more comprehensive approach to STIs and viral hepatitis, as far as screening and linkage to vaccination and linkage to care and treatment for those who are diagnosed with chronic hepatitis, but also linkage to HPV and cervical cancer services. So let's look at PrEP as really part of more comprehensive sexual and reproductive health services. The follow-up is every 3 months. And again, it's not just about repeating an HIV test to make sure that the person status remains negative, but it's an opportunity to address side effects, to reinforce counseling. And as we will see when Yanis will present on event-driven PrEP, is an opportunity to reassess the risk profile of the person and maybe change from a daily regimen to an event-driven one. So event-driven PrEP is part of the recommendation since July 2019 and is a specific schedule of dosing schedule for men who have sex with men that is linked to the exposure, to the HIV exposure instead of a daily dosing. And Yanis, I'm sure, will explain this in more details. So this is just to say that for countries wanting to implement PrEP, there's a variety of tools available and technical support from PAHO and other partners. So we really encourage to reach out to us and coordinate the necessary technical support. Over the years, as you can see in this slide, the PrEP policy uptake and implementation has really increased from 2017 to June of 2020, with 8 countries implementing PrEP policies, 6 countries implementing demonstration projects, but up to 14 countries in different stages of planning, either policy implementation or demonstration projects. We also know that in 13 countries, PrEP is available in the private sector, and in 5 countries, PrEP is available through the internet. But in some of these countries, there's no policy or project, so this is the only way that PrEP can be accessed. What we want to encourage is to have the more equitable access to PrEP and HIV combination prevention services as possible. We also see that there has been an increase over time in the number of people on PrEP, reaching about 20,000 in Latin America and the Caribbean at the end of 2019. So if we look at the breakdown by countries, we can see that the majority of persons on PrEP are in Brazil, Peru, and Mexico, which are the 3 countries of an important regional demonstration project called nPEP. 67% of persons on PrEP started in 2019, so it's a positive trend. We were hoping to have a larger scale up in 2020, but of course this will definitely be affected by the current situation of the pandemic. But out of the 20,000, the number of persons on PrEP in the Caribbean is less than 1,000. Most persons on PrEP are male, up to 84%, 4% are trans persons, and by age, 77% are between 25 and 49 years old, and it's about 18% that are youth between 15 and 24 years old. And by key populations, we can see that definitely the majority of persons on PrEP are men who have sex with men, 83%, and 11% are sex workers, 5% transgender persons. We analyzed current PrEP guidelines, either policies or projects or drafts, and I think the most important finding is that there's still a gap in at the policy level regarding access to PrEP for persons less than 18 years old. So we encourage countries to make sure that there are ways to offer PrEP to persons that are less than 18, also considering the sexual debut and the possible exposure to risk. And also the monitoring of STIs, while syphilis is available pretty much everywhere, the monitoring of chlamydia and Neisseria is included only in 40% of countries with policies or guidelines. Moving quickly to post-exposure prophylaxis, again, the first time that we see a WHO PEP recommendation beyond occupational and sexual assault is in 2014, when WHO starts recommending post-exposure prophylaxis to all exposed to potential risk, and with a preference for a 3-drug regimen. In the consolidated key population guidelines, WHO goes a step forward, mentioning that PEP should be offered to eligible key populations on a voluntary basis after a possible exposure to HIV. And again, this is not just for sexual assault, but is for what is called now a non-occupational PEP. PEP is part of HIV combination prevention, and as I mentioned earlier, is really strictly part of the same package of pre-exposure prophylaxis. And since 2018, 2019, the preferred regimen for PEP is a dolutegravir based, as most countries are moving towards this option. The implementation or policy uptake of non-occupational PEP is still limited in Latin America and the Caribbean. In 2017, only 39% of countries were offering non-occupational PEP, and we know that a new survey is going to be done shortly by UNDP, and PAHO is also participating. And really the actions that are needed are to encourage countries to update national policies and include non-occupational PEP in their guidelines, but also improve the knowledge and awareness both at the provider level and the community. Expand access to nPEP in the health system, and also monitor and evaluate the nPEP implementation. And to really move to the end, one of the best examples that we have in the region of the implementation of non-occupational PEP as part of combination prevention is Brazil, is really part of their concept of HIV combination prevention, and has specific communication material and messaging and tools around non-occupational PEP and where to access it. And as you can see in this slide, Brazil started nPEP in 2009. So there's almost 10 years of experience. And as you can see in the first year of implementation, the increase in the number of PEP offered in the country is really minimal, but over time it really picks up. And as you can see, the percentage of all cases of PEP that are classified as sexual exposure because of consensual sex starts with as a 3%, but over time it really goes up and now represents the majority of PEP dispensed in the country. But this happens gradually over time. And I think this is an important slide, because it shows that, first of all, we're not going to face a sudden and increase in nPEP, but this only happens over time. But also it shows that there's demand and there's need for this intervention. And we can see that for nPEP, the vast majority is, well, actually it's distributed with 40% in key populations, being 30% gay and other MSM, but also in the general population. And 37% of MSM that use non-occupational PEP are youth. So I think with this, I, of course, will encourage you to access the PrEP implementation toolkit, but also move to the next presenter, my colleague and friend, Yanis Mameletzis.
Thank you very much, Giovanni, for the excellent presentation, which highlights the overview of PrEP and the toolkits that are available to support its implementation. And I think we all take note of the 2 countries that are providing PrEP in the region and the total number of persons that are on PrEP in the Caribbean. So at this time, yes, we will hand over to our colleague Yanis, who will be doing the next presentation. Yanis, so the mic will be transferred to you now. Thanks.
Good morning, everybody. Can you hear me?
Yes.
Great. Thank you so much for that kind introduction. And I will share my screen. And can you see my screen, everyone?
We can see it. We can see it, yeah.
Great, thank you very much. Good morning, everyone. I'm Yanis Mameletzis. I am an epidemiologist based in Geneva. I just came back to Switzerland, in fact, after a 6-month assignment in my home country of Greece, working on COVID-19, and also trying to get PrEP introduced in my country. Thank you, Giovanni, for that great overview of WHO's guidance, both on PrEP and nPEP. I myself had worked back in 2015 and through 2017, 2018 on both the clinical guidance out of WHO on PrEP and also the PrEP implementation tool that Giovanni highlighted. So today, I'm here to provide a little bit of insight into what's new around PrEP. First, I just want to state that there are no financial conflicts of interest to declare. And in terms of the overview of my presentation, I will expand a bit more on what Giovanni touched upon as far as event-driven PrEP. I find it very exciting, in fact, that many countries in your region are looking to or are incorporating event-driven /211 PrEP in national guidelines, and that's, I think, a very important development. In addition, I'm going to speak to some of the PrEP products, other PrEP products that are in the pipeline. So when we talk about PrEP, that's synonymous with oral PrEP, so TDF-FTC or TDF-3TC. But as I will show you, there are other products that will be added to our HIV prevention package in the next few years. And lastly, really just underscoring how some countries have adjusted their PrEP services in the context of the COVID-19 pandemic. So 211 is the term that I like to often use. I think it's sort of conceptually very easy to grasp. However, in the literature, you see the terms event-driven PrEP, event-based PrEP, or on-demand. So they're all the same. WHO's guidance is very specific to the use of event-driven PrEP, however. Here, I just want to highlight the whole range of studies, over a decade's worth of PrEP clinical research that has resulted in WHO recommending oral PrEP so far. I'd like to draw your attention to, second from the top, is a very important study. It's called the EPRGay event-driven study that demonstrated an 86% reduction in HIV acquisition in those that used PrEP as event-driven. And so that was a critical study that led to WHO recommending this as a dosing option. There's a list of other studies in there. I'd also like to draw your attention to something that I will speak in a few slides. It's in the light blue. They are the ring studies. It's the ring study and the Aspire study there, as you can see. And this is a silicone vaginal ring that showed effectiveness as well in clinical trials, and more on that in just a bit. I think it's important to be very clear as to the two dosing approaches the WHO recommends for oral PrEP. And daily dosing is something that is recommended for anybody, irrespective of gender. So that goes for cis men, cis women, and transgender populations. And this is typically for people who are at continuous risk for HIV. They cannot plan their sex, and therefore this is the dosing option that is most convenient and effective for those individuals. Whether you're a man or a woman, the lead-in dose is 7 days before you engage in your period of risk. So that's, in other words, condomless sex. So that's a pill every single day for a week. And then there's also a washout period. So after your last sexual risk exposure, then you keep taking a single pill for 7 days. However, the evidence based on EPREP and also implementation research has led us to at WHO recommend event-driven PrEP. And so Giovanni highlighted it as well, but I want to show that here in this slide. So an individual who has typically sex once a week or not that, and they're able to plan their sexual activity, they can benefit from this dosing approach. So it's 2 to 24 hours before sex, you take a double dose, those 2 pills, and then you take 2 consecutive single tablets after the initial dose, and they're spaced 24 hours apart. So this is obviously for somebody who can manage to figure this this dosing strategy. And as providers, if you have any sense that the individual in front of you doesn't feel too comfortable with this, and it really daily dosing may be just easier on the brain, then you really encourage those interested in taking PrEP to take daily dosing. But it's definitely an evidence-based option that is highly effective and just as effective as daily dosing. And this only applies to MSM, no other population. So we have no data in women, in cis women or transgender populations, and therefore WHO only recommends 211 for MSM. It's contraindicated in individuals who have chronic Hep B infection. That is because of concerns for liver flares. Tenofovir is the same drug that is used to also treat active Hep B infection. And so it is, as it currently stands, WHO does not recommend event-driven PrEP for somebody with chronic Hep B infection. As I noted, there is no data to show efficacy, effectiveness of this in cis women. We're in fact concerned about missed doses in women more than men, and therefore, based on sort of the unique pharmacology of this drug in women, ED.PrEP is not recommended. And also, this goes for transgender persons. There's also some limited evidence suggesting hormones may reduce levels of tenofovir. Mentioned the EPREP study. It was not the biggest study, but it was a very important study and well conducted randomized clinical trial in 400 individuals. Then what really pushed WHO and partners to consider the recommendation of 211 as an additional dosing option for MSM was a large observational study of PrEP in Paris, in the Paris region, where individuals were offered both event-driven PrEP and daily dosing. And that also showed the effectiveness of event-driven PrEP in that population. It's important to also highlight that in addition to WHO, many national professional society guidelines have endorsed event-driven PrEP. You can see that on the slide. Interestingly, the United States has the largest utilization of PrEP. So that's the most people taking PrEP right now are in the United States, but they only recommend, according to the US CDC guidelines, daily dosing. However, cities have moved ahead of the CDC guidelines and are recommending and are actually implementing 211 as well. And we know from experience that individuals in communities and key populations, most definitely MSM, in all corners of the world, have access to the information from the internet, and they know what 211 is. So even if it's not in your national guidelines, people will still end up doing 211 on sort of on their own. And I think for the clinician, it's just really important to be aware and counsel individuals as to how to start and stop safely. From the perspective of monitoring and evaluation, I know sometimes we all want to know what exactly people are doing at any moment in time. But in real life programmatic settings, I think it's what happens is people will switch from daily dosing to 211 and back, from one side to the other. What is just helpful upon intake, and here's an example from the Morocco PrEP program, is to just capture what people's preference is before starting PrEP. So after you counsel and describe what PrEP is and how to take it, and if you have an MSM in front of you to offer both options, then you have that ability to capture what their preference is. In some settings, particularly with younger MSM, the provider steers the individual to take daily dosing as opposed to 211. But I'm a believer in having a conversation with one's client, and so I think this is is left to the provider. In terms of acceptability and preference, when MSM know about event-driven PrEP, and this is unfortunately a skewed sample of countries showing a proportion of MSM choosing event-driven PrEP. It's from largely European countries, US, and we also have China in the mix there. And there is a proportion of MSM, ranging from anywhere from sort of 20 to 50% that would choose PrEP. But it is an option that should that is as highlighted over this presentation, evidence-based, WHO recommended, and individuals MSM want this. In a technical document that we produced at WHO last year on event-driven PrEP when the recommendation was made and released at IAS, I think it clearly highlights the potential risks around this dosing option. They are, people can forget to take their post-sex dose if they're not in habit of taking a pill every day. Like daily dosing, 211 could fail. So nothing is 100% in effective in medicine, even though we state that it's over 90% to 99% effective. There are concerns always with resistance, and also in some settings, if you're going to capture on a form, on an intake, 211, that flags an individual as being MSM. So there are concerns around how this dosing approach is captured. It's always really helpful to have for the community, individuals, very clear information around how to take event-driven PrEP. I'm just flagging here the Dean Street Clinic in London, which has very, very clear and helpful information as to this dosing approach. These are some quick bullets here, points that I've just been mentioning over the past few minutes. In terms of other products, as I noted, when we talk about PrEP, we talk about oral PrEP, but in the next few years, we're going to be talking about other forms of pre-exposure prophylaxis. So we're in a very exciting territory. End of July, WHO, in partnership with the European Medicines Agency, approved the use of this silicone vaginal ring that contains dapivirine. So women insert this in their vaginas once a month, And this is this collaboration between WHO and the European Medicines Agency is known as Article 58, and this was an important development in global HIV prevention, offering women more options on the ground, hopefully. The work on the Depivirine ring was led by the International Partnership for Microbicides. There's more information here for you to look at after this presentation. And this was like many years of work and investment on the part of IPM and other partners. The two big trials are called the Aspire and the Ring study. They were phase 3 clinical trials, and they both demonstrated the vaginal ring reducing HIV incidence by an estimated 30%. So you tell me 30%, Yanis, is not that fantastic. You know, how can this compare to oral PrEP, which is, you know, over 90% effective? The reality is that it worked, but it did not work as well as oral PrEP. In both these studies, women were randomized either to take the ring or to take placebo. So they were not randomized. There were not non-inferiority trials. And in addition to these two RCTs, there are also the open label extension studies out of these RCTs. So in considering also data from HOPE and DREAM, WHO, I believe this was last week. I was not part of this meeting. It was a guidelines development group meeting that has come to a decision and has made a recommendation on the vaginal ring. And I think the decision right now is to determine what will be the effectiveness, because HOPE and DREAM, the open label extension studies, actually showed a higher rate of effectiveness in the vicinity of 50%. So that's something that will be another option for women, especially in high burden HIV settings. Next, cabotegravir. This is a long-acting injectable that is given every 2 months. There's a lot of work that's that's gone into designing and conducting 2 large international trials, HPTN-083. This is a study in MSM and transgender women, and also HPTN-084, a study in sub-Saharan African women. 083 has been completed. 084 is still waiting to be completed. This is a study schematic of what HPTN-083 is. It's a randomized double-blind study. In the both groups actually start taking for 5 weeks an oral pill of cabotegravir or the placebo, and then those that have been randomized to take the injectable shot do so for over the course of 3 years of active drug, and they also have to take an oral pill. In that context up there, it's as you see in the cabotegravir arm, they also have to take a pill every single day in addition to those injectable shots every 2 months. The other thing to note is the group that is randomized to taking the active drug of tenofovir and emtricitabine. They obviously take a placebo injectable. And so this was a long study. In fact, it's over 3 years and a very well conducted, well thought out study. What did the study show? They showed HIV incidence, a pooled incidence of 0.81 per 100 person years. There were 52 HIV infections that occurred in the process of this study, and there were 39 infections, HIV infections, in the FTC TDF arm, in the oral PrEP arm. Well, there were only 32 infections, HIV infections, in the cabotegravir arm. As a result of this this data, the study was prematurely stopped in spring of this year, and this data was presented at AIDS 2020. So there is this product has not been there is no regulator that has given approval for this product, but obviously there's very active discussion on the part of FDA, European Medicines Agency, and also WHO to see how we move forward with this. But this, yet again, could be another option over the next 1 to 2 years for countries. You may have also heard of Descovy or TAF-FTC. TAF is a prodrug, tenofovir. It has a faster absorption than TDF, and higher concentrations of the active metabolite in the cells. And as a result, it leads to sort of lower drug levels in the blood and less impact potentially on the kidney and the bone. And so there was this non-inferiority study that was conducted by Gilead Sciences comparing TAF-FTC to TDF-FTC in cis men and transgender women. This was a study of when over 5,000 people. It was conducted over the span of 96 weeks, and it was completed last year. What did that study show? It showed non-inferiority with 15 HIV infections in the tenofovir emtricitabine arm versus 7 infections in the TAF arm. As a result of the DISCOVER trial, the company, Gilead Sciences, put in an application to the FDA to extend the PrEP indication for TAF-FTC. And they received that last year. It is only in cis MSM and transgender women as a result of the fact the study was focused on and included this population. There's some work currently underway in cis women, and that may influence whether there's an extension for using TAF-FTC for PrEP in women. There is a really great article that I welcome everybody to read that looks at, that examines what is the added value of TAF-FTC potentially, and it was published in the Annals of Internal Medicine in the beginning of this year before we all had to deal with COVID-19, and I really welcome everybody to read that. So it's not necessarily the unquote better or safer option. So there's much more nuance as to what would be the utility of TAF-FTC at a programmatic level. So for now, we have TDF-FTC and TDF-TC in our countries. It works extremely well. It's already in our supply chains. It's used for treatment. Unfortunately, in some countries, or in many countries, it's yet to be implemented as PrEP, and WHO, of course, encourages countries to move forward with those drugs that are deemed to be essential medicines. Now, finishing my presentation, I really want to just speak to how some countries have shifted the way they're offering PrEP in the context of COVID-19. Obviously, in my country of Greece, we have yet to start PrEP, as in some countries in the region, and nonetheless, I think there are still opportunities to be creative in thinking how you can start with even a pilot or a demonstration project or some other way of integrating PrEP, even in the context of COVID-19. Cost of inaction of in terms of what COVID-19 is doing for HIV treatment programs is very serious. This has been also highlighted by modeling work that WHO has put out there. This was a modeling study that actually came out in May, but published in the Lancet in August 2 months ago, and it really just shows what what a 6-month interruption in ART supplies can have on excess deaths. We also recognize the interruption in prevention services and people not being able to access PrEP with an increased risk for acquiring HIV. So even in lockdown and in COVID-19 times, people still engage in high-risk behavior, and therefore PrEP is established and is offered as a service that should be continued. If PrEP has yet to be introduced in a country, that COVID-19 should not be used as a as a reason for not thinking carefully how to offer that. So COVID-19 is that major disruptor. I think what countries are, we know what countries are encouraging, as far as HIV is concerned, to decrease the contact for individuals with health facilities. For HIV treatment, many countries have shifted towards MMD, multi-month dispensing. And telemedicine is or telephone triage is something that countries, whether they're low middle income countries or high income countries, are resorting to, and also courier services, so delivering PrEP. And this is, something that can ensure some level of access. Oops, excuse me. As you all know, Brazil has suffered from COVID-19, but even in Rio de Janeiro, they ensured that there was some level of continuation of PrEP, even as COVID-19, took a hold in that city and the rest of the country. And this is just a schematic of before people on PrEP, before they had to come to clinic. Importantly, there's that initial telephone consultation, and that's also an opportunity to screen for suspect COVID-19 symptoms. So what Brazil did was a mix of like telemedicine, but also get people to come to clinic as well, in order to undertake their sort of initial HIV rapid test. So there's a reference there if you're interested in this article, which was published a few months ago. In Thailand has a very successful PrEP program. It's key population led. So it's the key populations lead in the design and the delivery of PrEP. So they dispense PrEP. It's doctors have to prescribe, but they often do it remotely. And the individuals who want PrEP come to a community-based key population service, and it's another member from their key population that is the one who's doing the screening and the dispensing of the drug. Now, in terms of limited movement because of COVID-19, and also concerns around the supply chain and stockouts, the messaging to MSM using PrEP was that they should use, undertake what's called effective use. And so given concerns that you may run out of drug, MSM were also encouraged, where possible, to use PrEP as event-driven, rather than taking a single pill every day if their sexual activity was very limited. So 211 definitely has, I think, a very interesting role in times of COVID as well. This is data from Boston, very large mature program on PrEP. They had a lockdown in end of March, and as you can see here, the PrEP refill lapses increased by almost 200% from the period of January to April 20th. Also, new PrEP initiations decreased from the period of January to April 20th by 70%. So here on this slide, you also see that initially all consultations at this Boston PrEP service were in person. By the time of the lockdown in end of March and April, there is a shift towards people resorting to PrEP services by telemedicine. I am just a few more slides, and thank you for your attention. Dean Street Clinic is I always show this as an example to individuals who are decision makers, to demonstrate the impact of PrEP at a clinic or at a city level. This is in London. Dean Street is a high volume sexual health clinic. The individuals attending this clinic, by the end of 2015, they started taking PrEP and buying it online. And they reached a sort of critical point at which that blue line is new HIV diagnoses. And you can see at the end of 2015 through 2016, that blue line, HIV diagnoses, reduces significantly. The number of HIV tests, the red line on top, nothing changed. It remained pretty constant through the period of January 2015 to September 2017. So over that course of 2 years. So the only thing that happened towards the end of 2015, a lot of guys got on PrEP, and that led to a reduction in HIV diagnoses, which is what we all want to do. So Dean Street, a very mature PrEP program in a resource-rich city. When they got hit by COVID, the clinic opened up, but as in many places all over the world, staff were redeployed to help with the COVID-19 response. In terms of STI and PrEP management, what they did is they created a telephone triage. And they deferred callers to defer their attendance. And they also delivered postal testing kits for STIs. And this was obviously something recommended to those who were using PrEP. As I conclude my presentation, I just want to show that this is something from Vietnam. A lot of innovation in that country. I know it's in sort of the other side of the world, but I think we can draw lessons from what they're doing also in Vietnam from HIV self-testing. They really used the ability to reach out to individuals, key populations, through online risk assessments, and they were able to deliver HIV self-tests by mopeds. They have this service called Grab in Vietnam. And again, if we're thinking about innovation in the Caribbean, whether it is HIV self-testing or PrEP, we need to be creative in times of a pandemic. And so that's why I wanted to highlight this to the participants today. Lastly, we have in many countries gene experts that are utilized for TB or HIV viral load. PrEP is an opportunity to test and more appropriately and do better management of STIs. And so there's no reason why we cannot think about cartridges for gonorrhea, chlamydia for those gene experts that are in our settings. So I think that's just something to highlight for those for those working in HIV STI programs. Key points to conclude: 201 should be included in national guidelines for PrEP. It's a very important development in your region to see that is happening. In fact, as I highlighted, there are more products coming in the pipeline for HIV biomedical prevention, and I think that's something to look out for. And lastly, we want to diversify the existing PrEP models that we have, and we also, if PrEP is not available, the kind of PrEP model service delivery platform has to be flexible in your country. So think about longer PrEP refills, so maybe not just 3 months, it could be 4 months potentially. You want to think about how to bring PrEP closer to people's homes, so that could be a way of having a courier service or people, community-based organizations, key population groups bringing PrEP to clients, and also thinking about moving, PrEP dispensing out of the hands of the clinicians and really having more involvement with peers, community providers on that front. And lastly, I think this is a message underscored by Dr. Mike Ryan at WHO. In the context of COVID-19, we need to think of the community dimension. We do this quite well in HIV compared to many other sectors in public health, and I think we need to just keep pushing the envelope around community-based delivery of PrEP and other HIV prevention services. And thank you for your time and attention. Over to you.
Thanks very much, Yanis, for that very informative presentation and for sharing with some of the more recent technology that is on the market, such as the recently developed vaginal rings for HIV prevention among women, and the experience you shared from other countries, especially as it relates within the whole context of COVID, which is very much important because we know we will be living with COVID for some time to come. Right now, we have had 2 presentations, and we would want to take 10 minutes to hear from you if there are questions, clarifications that participants would have at this time. Please feel free. As I mentioned earlier, there is the raised hand that is next to your name. You could press the raised hand and the mic will be released. So I now turn over to any questions that you may have. I don't see any raised hands. We have one. Miss Alindrina Wong, you could go ahead, please.
Are you hearing me? Okay. I would be very grateful if the second presenter would just highlight again why TDF, FCT, TAF, FCT. What are the major differences there, and why is one preferred over the other? I may have missed some of it on the slide.
Thank you very much for your question. Just to clarify, are you referring the difference between TDF FTC to TAF FTC?
Yes, thank you.
Thank you very much. So what was observed in that major trial called Discover, which was only in MSM and about 80-something transgender women, if I'm not mistaken, is non-inferiority between the two between the two different drugs. So we cannot say that TDF FTC is superior to preventing HIV to TAF FTC or the other way around. As I mentioned, because there's the amount of drug you need. So TAF FTC is something that has FDA approval and is used by many countries for HIV treatment. And so there's on two things. The potential long-term impact of TAF FTC on kidneys maybe for renal function may be more favorable than TDF FTC. TDF in itself is nephrotoxic. HIV infection is also in itself nephrotoxic. So as Giovanni noted, we ensure that we conduct creatinine tests before somebody is initiated on oral PrEP using TDF-based PrEP. And that is because we just want to ensure that somebody's kidney function is such that TDF will not do more harm than good, obviously, in preventing HIV. So there is that potential for less toxicity, I would say, with TAF FTC long term, but that's really not necessarily demonstrated from the data that we have. And I think that's why WHO currently has not moved towards recommending TAF FTC for PrEP. The other thing I just want to highlight is that we also want to ensure equity for HIV prevention products. So we want to make sure that women who represent over half of people living with HIV actually have access to a product. So I gave you a description a bit on HPTN-083, the long-acting injectable. That's a study that was undertaken in men. The company that developed cabotegravir, the injectable shot, also has invested in doing a big study also in women. That was not the same. That was not the case with TAF FTC. So, but yes, there may be a marginal benefit on the safety of TAF FTC on the kidney. And potentially on bone health, but the data from the trial doesn't necessarily give us a resounding sort of evidence on that. Thank you.
Yes, and Yanis, if I may complement, I think on the other way around, the profile of safety with TAF showed an increase, a weight increase, significantly higher than with TDF. So that's another aspect of the significance from a metabolic perspective of the long-term use of TAF, which is something that is also being observed in the use of TAF versus TDF with dolutegravir for HIV treatment, so a long-term exposure. So I think you have to put that into the and weighing that in the balance of the safety perspective. But I think from a public health perspective, you are also comparing a PrEP combination that is approximately $5 to $6 per month with another one that is not yet available as generic, and it's much more expensive and possibly not affordable in many settings.
Thanks. We have another question from Lester Guy. Lester?
Oh yeah, sorry, Sandra. I was just wondering for the ring study, vaginal ring study. I'm not sure if you mentioned how long is that event-driven thing where you use it just before you have sexual intercourse, or is something that stays for a while? Can we put how long it stays? I was just curious to find out.
Dennis, would you want to respond to his question? The use of the ring, Lester is asking about the use of the ring for HIV prevention in women and how long the ring is used for. I think if I understood him rightly.
Yes, so the in the trials, it's a ring that is a monthly ring. So it's used for, so women like in the span of a year would get 12 rings. There was challenge in terms of the use of the vaginal ring in the younger women, and we saw sort of lower effectiveness being reported according to the trials as a result of that. And so adherence to a ring is very different from measuring tenofovir drug levels with oral PrEP within a study. So there's I think there's a gray zone of uncertainty around the adherence measurements in the study, but it's something that's used on a monthly basis. And can really complement a woman's sort of option to use some form of HIV prevention. So if my personal take is, and there's no WHO, well, there is a WHO recommendation, but right now, but I don't officially know what that recommendation is. But I think what will come out most likely from the guidelines meeting, and just I'm just using my sort of my experience. It is oral PrEP would be, because we have a really high quality evidence and on effectiveness as well from so many years of implementation, but from research and actual implementation, that it's almost like your preferred option. And the vaginal ring would be almost an alternative option. So women that can, for whatever reason, they cannot or they will not take oral PrEP, they will have another option to keep themselves HIV free. And so I think that's right now WHO guidance does not, unlike treatment, there's no sort of preferred versus alternative drugs or regimens. We currently really recommend only one product, and that's TDF based PrEP. But as of last week, we're moving towards also having another option. I would suspect maybe foreseeing over the next year or so a recommendation on long-acting cabotegravir as well. Over to you.
Okay, thanks. We have one other question from Jesner Orlando. Can you go ahead, please? It's Jesner Orlando. Do you have a question?
He just needs to unmute his
Hello,
mic.
can you hear me?
Okay.
Hello?
We can
Yes,
hear
we
you.
Yes,
We can hear you.
sorry about that. My question was that there's a lot of research that has been done with the MSN population and transgender population in terms of the PrEP and the PEP, but has any research been done amongst female sex workers and their use of PrEP or PEP? And also another part of that question would be, how does the ring work in terms of multiple sex partners in one go in reference to a sex worker versus the Dapivine? Which one of the two would have been, I would assume, a better option in terms of usability and frequency of a sex partner? Because I know with pursery stuff that go into the vagina, and men come in different sizes, and you never know what kind of a person that will have intercourse with this woman that could probably tamper with the placement of the ring, because I'm not very familiar with the ring. But having experience with other intrauterine devices, it does play a role sometimes if you're having more than one sexual partner. In summary, it's really, I would like to know, is there any research that has been done with PEP and PrEP in terms with sex workers, and specifically with female sex workers?
I can answer Giovanni, and maybe I can answer part of the PrEP question related to sex workers, and also on the Dapivine ring, and then over to you on. So thank you for your question, sir. So related to the PrEP evidence in sex workers, there is limited work from the clinical trials in sex workers, but we have actually had a lot of well-designed implementation research and actually programmatic rollout of oral PrEP in sex workers. So from my source in Calcutta in India, where you saw community-led PrEP in sex workers, which led to really high levels of adherence, because sex workers had real ownership of the PrEP program in India. And I think that really made a critical difference. And that's that piece of work in India has been shown as being kind of exemplary. In terms of South Africa, has one of the largest PrEP programs in sub-Saharan Africa, so it's South Africa and Kenya, and their initial rollout was in sex workers, and that also was their programmatic rollout in 2016 was also a function of some demonstration projects in sex workers as well, and some evidence also on PrEP implementation research from Zimbabwe as well, and a few other countries. And so there is there is high acceptability, but it's it really varies from population. Now to your other question about the frequency of sex partners and the and sort of the kind of how that's related to the ring's effectiveness performance, I cannot answer that question. I'm happy to follow up with that with those that are much more were much more involved, like the principal investigators from the Aspire and Ring study and the open label. So I'm happy to find out more about that. Also, a question that's been asked to me over the past few days from other colleagues has been, Yanis, what is going on between taking the ring with oral PrEP together? And to my knowledge, there's no study designed yet on that topic, which would be actually, particularly interesting, because if women, for whatever reason, remove the ring, but are still exposed to HIV after they remove the ring, obviously having drug levels in them with tenofovir, I think, would also may offer that extra layer of protection. So, but I'm not answering your question, I know that, and I will follow up on that, sir. Over to you, Giovanni.
Yeah, so just a couple of comments. I think in the recent discussion in WHO about the dapivrin ring, the experience or evidence from the use in key populations and specifically female sex workers was recognized as a gap in knowledge. So and I haven't seen any result presented or analyzed by frequency of sexual acts or multiple partners, but we can definitely follow up with the researchers. One consideration about oral PrEP in sex workers, in many countries, it hasn't been prioritized necessarily as a population group because of the trend in reduced prevalence over time below 5% and the very high use of condom above 95%. And regional networks of female sex workers have also positioned themselves a few years ago quite strongly against PrEP because they don't want PrEP to, let's say, dismantle or substitute the condom use as their main tool for HIV and STI prevention. Having said that, there's, I think, in like more recently, there's more interest. At least we've been approached by civil society organizations. So we're very happy to explore how PrEP, oral PrEP, or the new PrEP tools can be strategically used by female sex workers. Maybe that 5% that for any reason is not able to use or use consistently or negotiate the condom. So I think there is certainly space for use of PrEP in sex workers.
Can I just squeeze one quick comment in before we leave?
Yeah.
One quick thing I just wanted to confirm or probably to verify. So basically, from what I've heard between the both of you is that when someone is using the PrEP, they normally are not using condoms. Where I was thinking that if the person were on PrEP, they would be using the condoms, and the PrEP would be sort of like a emergency, just in case a condom were to break, that you would at least have a secondary sort of protection. Because in the part of the world where I live, many men have these raised beads on their penises, and these quite often break condoms. And then you have a situation where a woman is concerned and may be infected because a condom got broke. But should a woman be taking PrEP and also the man using a condom, wouldn't that sort of reduce even more the risks versus just one or the other? Like just having condoms alone or just PrEP alone? I thought it was more of a combination of the two to ensure that either side is protected.
That is correct, and I think the important message is that PrEP protects against HIV only and not other STIs or viral hepatitis. So definitely the combination approach is the recommended one.
Yes, just also to follow up on that, I think, yeah, just that message needs to be clear to individuals. Of course, people taking daily dosing PrEP, sex is dynamic. So you may have multiple partners, and you may have partners that, you may have a partner that you don't use condoms consistently or ever. And then you may have, at the same time, other partners with whom you use condoms consistently. And this may be also relevant to sex workers as well. And so to Giovanni's point that, of course, we're not here to disrupt condom use, but I think there's also, we are trying to offer individuals evidence-based options that will keep themselves HIV free. As far as PrEP is concerned. PrEP is, of course, because it's available, it's really engaging people around their sexual health, sort of more broadly. And so when we say that, oh, well, the fact that you're offering PrEP means you're also having the ability of people coming into clinic and being able to be tested for the other STIs. HIV, of course, being one of those. But for the other bacterial STIs, PrEP is, again, a great opportunity to, test and treat more effectively. Lastly, I think for sex workers specifically, there's, sex workers, we need to be conscious that, a sex worker, whether that's an MSM or it's a cis woman, whatever that individual, whoever that is, sex workers engage in sex with their clients, but also engage in sex with their non-clients, with their steady partners or whoever else that may be, and so they may use condoms consistently with clients, but not use condoms consistently or ever with some others. And so I think when we're talking about high HIV incidence settings, right, we need to think, have an open mind to the role of PrEP in that setting.
Okay, thank you very much. I think there were some very interesting questions. I know we have one other hand up, but I would just ask you if you could just kindly just hold your question until we finish the other two presentations. At this time, I would like to move with the country experience and move to the presentation by Dr. Anton Best, the Senior Medical Officer of Health and the Manager of the HIV STI program in Barbados. For most of you, you are aware that the Ministry of Health in Barbados, under the guidance of Dr. Best, has established and implemented PrEP for the past 3 years. And so today, Dr. Best is going to actually share with us the experience and the knowledge that they have acquired over the years in the implementation of PrEP. So Dr. Best, I turn over to you. Thanks very much.
Thanks a lot, Sandra. I just want to confirm that you can see the screen okay and that you can hear me.
Loud and clear.
Okay, fantastic. All right, so good afternoon, everyone. Let me begin by thanking the organizers of this virtual training for the opportunity to share a bit about the Barbados experience regarding PrEP. Sandra, you just mentioned the experience over the years, so it's a little bit daunting to believe that we actually have accumulated years of experience. It's almost 3 years that we've implemented PrEP. And it started off as a rocky road, and I'm going to talk about the experience implementing PrEP and the challenges that we have faced. So the objective is to provide an overview of the Barbados experience implementing PrEP, and we're specifically looking at the period March of 2018 when we started to just about the end of last year. And the reason for this period is this is what we have done. And when I say we, myself and Dr. Nastasia Rambaran, who is participating in this webinar, we drafted a manuscript and have submitted this manuscript for publication. And this is the period that we looked at. I'm also going to talk about what has happened since the end of November of last year and talk about the impact of COVID-19 and other factors on the provision of PrEP services. So I'll touch on the rationale for implementing PrEP in Barbados. Why is it that we thought we needed to implement PrEP? And then I'll summarize the Barbados experience by looking at some key milestones and the assessment of the program as articulated in the draft paper that I would have mentioned. And then I'm going to touch on the programmatic gaps that we have identified and what we need to do going forward. So the prevalence of HIV in young adults is estimated to be 1.5% in Barbados, which is relatively high. And this is UNAIDS estimates at the end of 2019. The prevalence of HIV in MSM is significantly higher at about 12%. And we presume that the HIV prevalence in other marginalized populations are higher. Definitely, there are vulnerabilities that we have identified, but the level of evidence that we have for the MSM population, we don't have in those other groups. Also, to bring into the rationale and as part of the discussion is what is happening with other sexually transmitted infections. And what we realized looking at our data, we've had sustained high rates of both chlamydia and gonorrhea for the last 10 plus years, 10 to 15 years. Our most recent prevalence data and incidence data showing 12% prevalence for chlamydia and just over 3% for gonorrhea. Also bringing into the mix, we have to take a look at syphilis. We have noted a sustained increase in the rates of syphilis after an outbreak that occurred just about 8 years ago. When we look at our behavioral data, we do behavioral surveys approximately every 3 years. We realize that there are high levels of knowledge, but that those high levels of knowledge do not necessarily translate into sustained condom use and changes in behavioral practices, hence the justification for other prevention modalities. And you would have seen this slide earlier, I believe it was Giovanni's presentation, where essentially we're talking about PrEP as a biomedical intervention, but we cannot forget the other components of prevention. We have to consider the structural, we have to consider the behavioral, and then we have to consider the other biomedical modalities as well. It's important to appreciate that the PrEP program must be nested within that combination HIV prevention approach. It's not to usurp any other prevention modalities, but rather to work synergistically. And just as a reminder that we are all gunning towards the end of 2020, which is practically upon us, and 2030 in terms of the Sustainable Development Goals, we have commitments to ending HIV, STIs, and viral hepatitis as public health problems. This is international, but we're focusing on regional. And we have some targets that we need to meet. So looking at the key milestones, I would have mentioned that we started PrEP in March of 2018, and we started it at the Lady Mead Reference Unit, which is an HIV and STI specialty clinic. We essentially started it then as a pilot, where we never advertised that we had PrEP. We relied on word of mouth, particularly amongst the MSM community. We really wanted to see how our guidelines were being implemented. We wanted to try out the tools. And of course, we were making adjustments along the way before we opted to increase access to PrEP and have more people aware that PrEP is available in Barbados. Later in 2018, led by one of our NGOs, in particular Equals, we hosted focus groups with key populations because we wanted to know what their thoughts were about PrEP. We wanted to understand the myths, and we wanted to understand how is it that they wanted the service delivered. This was very important to be able to feed back into the programmatic elements of the PrEP service, as we wanted to offer PrEP particularly to key populations. In September of 2018, just over 2 years ago, we had training of providers, and this was facilitated by our colleagues at the CDC and PAHO. And in early 2019, we started PrEP at an NGO site, Equals. Equals had partnered with us from the very beginning, but we wanted to offer PrEP at the NGO site because we did have indication that persons would prefer to access services there. In May of last year, we resumed an STI clinic at our main polyclinic, at the Winston Scott Polyclinic, which is adjacent to the Lady Mead Reference Unit. And we did that using a visits approach, which included a PrEP referral. And this is important because we did this revamped STI clinic under our CDC cooperative agreement, which has come to an end at the end of September. And I'm going to talk about that in terms of the impact that the cessation of PEPFAR support is having right now, not only in terms of PrEP, but in terms of HIV and STI services. So just 2 weeks ago, we had a second major training endeavor, and that was supported by CDC and the University of California, San Francisco. And by the end of 2020, we intend to roll out PrEP at other sites. In particular, we have identified a polyclinic and the Barbados Family Planning Association. So the next few slides, which is the crux of the presentation, is essentially the manuscript that I would have referred to earlier, the title of which is Evaluating the Early Outcomes of the Barbados HIV Pre-exposure Prophylaxis, or PrEP program. So progress to date. So between March and November, March 2018 and November 2019, we had 134 PrEP enrollees. Over the following, that's what, 10 months, between December 2019 and the beginning of September, we had an additional 17 persons. The numbers are small, but as you can imagine, we've heard it many times already, we've had significant service disruption due to COVID-19, and I'm going to touch on that in a few slides. Of the 134 persons enrolled in the PrEP program, the majority are males. We have 6 women and 2 transgender persons. The split of where services are provided, so just as a reminder, it's 2 sites you can get PrEP at. It's the ECO site, the NGO, or at the government clinic, LRU, and it's approximately 50-50, bearing in mind that the Lady Mead Reference Unit was offering the service a lot longer than the EQUALS site. 2/3 of the client population are MSM. And of note, 20 persons on PrEP were in serodiscordant relationships, with 45% of those being men who have sex with women and 40% being men who have sex with men. So the majority of persons had no comorbidities, but that shouldn't be surprising. I believe the average age of a PrEP enrollee in Barbados is about 30. So just based on age alone, we don't expect many comorbidities, but out of those who did have comorbidities, the majority were asthmatics, and we did have a small proportion of persons with comorbidities having hypertension. Just about a quarter of persons stated that they always use condoms, and this is within the 6-month period prior to beginning PrEP. And just about a third of enrollees had 3 or more partners during this same period. It's important to appreciate that when we enroll a person into the PrEP program, not everyone actually starts antiretroviral therapy for the purposes of PrEP. So we had 6 such persons who did not commence the treatment after they were registered into the program, and the reasons being we had persons reporting that they had allergies to the drugs. We had persons who wanted to defer the decision to actually start. So we did the workup. We would have done all of the initial assessment, and then they would have said, okay, they want to think about it. We provided them with information, and then they would come back. Or in some cases, we had persons with comorbidities, which would have been a contraindication to starting PrEP or giving us pause to start. So when we tested persons at enrollment, we picked up quite a few cases of STIs. In particular, we had persons who had reactive syphilis titers. So important to appreciate that we didn't make the distinction here between whether it was an acute case of syphilis or whether it was an old case of syphilis. A few persons would have had chlamydia, and 2 would have had gonorrhea, and 1 person would have been positive for HTLV1. So in terms of follow-up testing at the 3-month and 6-month intervals, we detected 4 new cases of syphilis, 2 new cases of chlamydia, and 1 new case of hepatitis C. We did detect in 1 case, the minor elevations in liver enzymes is related to the case of hepatitis C. Shouldn't be a standalone point there. And we did have 1 patient whose creatinine clearance dipped below the 60 milliliters per minute cutoff. On follow-up visits, most persons reported no change in condom use. 25% use condoms less, and a small proportion use condoms even more since starting PrEP. So in terms of side effects, we noted that just about half of persons reported to have some form of side effects. These were essentially gastrointestinal in nature, or mainly gastrointestinal in nature. So out of all of those who had side effects, it was 3/4 were gastrointestinal, whether it was nausea, vomiting, bloating, gas, diarrhea, or abdominal cramps. But they were all short-lived. Persons also complained of having headaches, and some persons complained of having sleep disturbances, insomnia, vivid dreams, as less common side effects. So when we take a look at the WHO indicators, and there are 4 indicators that we're going to concentrate on: the uptake, continuation, PrEP-associated toxicity, and HIV positivity. So in terms of uptake, it's basically looking at the proportions of eligible persons who initiated PrEP within the study period, and that was 96%. So the proportion of people who actually started ARVs was 96. In terms of continuation, and this is defined as the number of PrEP users who continued on their medication for 3 consecutive months after initiation, disappointingly, that number is just under 2/3. So that proportion was just under 2/3, as a lot of persons were lost to follow-up. And I'll also touch on that when I talk about deficits in the program that the study helped us to identify. In terms of PrEP-associated toxicity, and that is defined as a proportion of people who received PrEP but discontinued it due to serious medication-associated toxicity. And that was a small proportion, that was 2.3%. And in terms of HIV positivity, so this is the percentage of people who tested HIV positive among those who received PrEP at least once during the study period and had at least 1 follow-up HIV test. And we detected 1 out of 64. And the reason for this one particular case is this is a guy that we would have enrolled into the PrEP program very early. However, he defaulted, so he never even came back for his 3-month follow-up. And when we picked up a year later that this guy had defaulted, and we called him in and said, look, you need to come back into the PrEP clinic. Of course, we would have had to do the workup, and including an HIV test. That's when we detected that he was HIV positive. So he had long defaulted. He was not on ARVs at the time of seroconversion. So continuing to look at the assessment and continuation of care. Continued care by the end of the study period, the majority of persons enrolled in care had enrolled at equals or continued at equals. It's important here to appreciate that no matter which site you started off at, the system that we had developed, the shared care system, you could have switched sites. So there were some people who would have started off at the Lady Mead reference unit, which again is a government site, but would have preferred to go to the NGO site for various reasons. And then the reverse is also possible, where you can start off at the NGO site and end up in the government site. At all times, the services are free. In terms of being lost to follow up, and this is defined as having missed an appointment by more than 2 months with no reason noted in the records, this was significantly associated with enrollment at the Lady Mead reference unit. So you did worse if you were at the Lady Mead reference unit in terms of being lost to follow up. In terms of the age of persons who were continued enrollment, we wanted to see a comparison if age made a difference. And what we found was that you were likely to be slightly older if you were sustained in care. So the average age of person sustained was 31.3 versus 29.5. I know it's not much of a difference, but still this difference was statistically significant. And it's important to appreciate here, as stated on this slide, that the staff at Equals were dedicated, meaning that using existing resources, in particular PEPFAR resources, Equals had a healthcare provider whose specialty interest was on the provision of PrEP. Whereas at the Lady Mead reference unit, we're providing PrEP, we're providing post-exposure prophylaxis, whether it was occupational or non-occupational. We're also providing HIV care. We're also providing HIV and STI screening and counseling and other related services. So we have less capacity at the Lady Mead Reference Unit in terms of being able to focus on pre-exposure prophylaxis. And this is something that was highlighted very clearly in the study results. Also looking at continuation of care. So what we sought to do here is to look at the different risk categories. So we have women who have sex with men, men who have sex with men, men who have sex with both men and women, and men who have sex with women in terms of the uptake and continuation. So in terms of uptake across the board, the uptake was good. So we enrolled you into the clinic. We deemed you to be sufficiently high risk and could benefit from antiretroviral therapy for the use of pre-exposure prophylaxis. But in terms of continuation, what we found were some significant differences here, where the rates of continuation were particularly low amongst men who had sex with women and men who had sex with men. And I'm going to explain those very shortly. So especially low continuation rates among MSM, many of whom were in serodiscordant relationships, may be due to better viral suppression in the HIV positive partners or discontinuation of the serodiscordant relationship. We weren't able to find out all of the reasons simply because persons were lost to follow up. So there was no possible way of easily getting the information to find out why people didn't continue because they weren't there. We weren't able to access them. Of the 20 persons who were in serodiscordant relationships, 13 were still enrolled by the end of the study period. One had discontinued because their HIV positive partner had migrated. One paused, and we have a note here about U equals U, but then restarted. And this was on the patient's own volition, where they thought, okay, well, my partner's viral load is now undetectable, so I no longer need to continue PrEP. That wasn't what we as healthcare providers advised, that's what they did, but then they decided to restart PrEP. And then there were other reasons for discontinuation, but we simply don't know because, once again, persons had followed up. Reasons for discontinuations were not analyzed by frequency since only a small number gave reasons, and these included side effects, difficulty to get to clinic, not being very sexually active, the partner had migrated. In one case, I believe there was incarceration. I think it was only one case. And then some people say, well, they're going to stick to their partner and continue in a mutually monogamous relationship, so they're no longer interested in PrEP. So what are some of the factors affecting the delivery of PrEP service in Barbados? So even prior to 2020, you have to appreciate that we were always in a resource limited or resource restricted setting. Even though Barbados is determined to be one of the wealthier countries in the region, our resources are still limited. We're still struggling in terms of sustaining health services across the board, and especially for HIV and sexual reproductive health services. Part of the context that you should appreciate is that there has always been a high demand for PrEP and an unmet need. And it's something that we need to continue looking at going forward, but it's even more trying now that we have COVID-19 to deal with. PEPFAR support has officially ended for Barbados. Equals, the NGO site, did receive substantial support by PEPFAR, and they would have closed, that PEPFAR support would have ended a few months ago. And then in terms of the Ministry of Health, we had a cooperative agreement with the US Centers for Disease Control and Prevention. And as I mentioned earlier in the presentation, that agreement ended just last week at the end of September. And all of these have had an impact on the delivery and access of PrEP in Barbados. And then, of course, COVID-19, it almost goes without saying. So we would have heard Rosman at the beginning of the presentation and Yanis also talking about COVID-19 as a major disruptor. What we haven't done for the purposes of this presentation, however, we haven't quantified the extent to which COVID-19 has had an impact. But let me just say very quickly that the COVID-19 impacted the delivery of PrEP services in two main ways. We actually had to reduce the number of services or the number of clinic visitations, PrEP being one of them. So we weren't putting new people on PrEP. We certainly weren't advertising PrEP because we know that there's a high demand for it, but we just always feared the capacity or ability to be able to sustain it. But then the other major way that COVID-19 has impacted us is in terms of stock out of Truvada and generic variants of Truvada. And when I specifically asked our pharmacy what was happening, they would have explained to me that we use a lot of generics. Generics are coming out of India, for instance. There was significantly reduced airlift out of India. So we were not able to get the drugs, and we were relying on distributors, local distributors, who get the generic drugs for us, but we simply had a breakage in terms of our supply chain. In terms of the gaps in the Barbados PrEP program, there's an overall low capacity to meet the demand and to ensure follow-up. You would have heard me illustrate that quite a few times during the presentation. We have to improve the capacity to be able to follow up PrEP enrollees, low continuation rates, need for better follow-up to ascertain the reasons for discontinuation or barriers to continuation. And then we also need improved capacity to do a better job at pre-initiation counseling. There's a need for expansion of PrEP services, especially to other high-risk populations, including women. So I conclude the presentation by saying that there's an urgent need for expanded and comprehensive and integrated HIV combination prevention services. And I sincerely hope that in the few minutes that I had your attention, that I was able to explain that and illustrate that need. So I want to thank you for your attention. And I especially want to acknowledge and thank my colleague, Dr. Rambaran, staff at the Lady Media Reference Unit and Equals, and staff at the wider HIV STI program and the Ministry of Health and Wellness, and all the patients and communities we serve in Barbados and the rest of the Caribbean. Thank you.
Thank you very much, Anton, for the wonderful presentation, which provides a very comprehensive assessment of the PrEP services in Barbados. And I think from the data shared, we could see what the uptakes are, and also for sharing the factors that is affecting the services of PrEP in Barbados. A quick time check, we are now at 5 minutes to 11. We were supposed to finish at 11 o'clock. So at this time, I would open for any question that you may have for Anton, and then we could look if you'll be able to facilitate another 10 minutes extra, then we could actually have Giovanni's presentation. But so this is up for discussion. But first, let's see if there are any questions for Anton. I see a first hand from Lester. So Lester, you can go ahead.
Yes, Sandra, yes, I'm here. I'm just unmuting my mic. A question I had for Anton is this. Do you have a breakdown of the persons who are on event-driven PrEP or people who are just taking the PrEP like on a daily basis? I would like to know, because one of the things that I've recognized, a culture that I've recognized around the MSMs in recent time is that there seems to be quite a challenge in the using condoms. So well, from my technical point of view, as I said, that time I've had discussion again during the COVID lockdown. I've had to do testing and so on. So I'm really curious to know if there's a lot of event-driven PrEP use, or if just there are persons who are on PrEP like normally and they take the pills every day. What's the percentage breakdown based on the population that they have?
Yeah, so Lester, let me thank you for that excellent question, because I actually forgot to mention event-driven PrEP. So there are two things I need to stress. Event-driven PrEP is not in our guidelines. However, during COVID-19, when we were having all of those challenges, and some of those challenges still remain to this day, of course, it was a lot worse at the very start of the COVID outbreak. We had no choice but to start event-driven PrEP. And let me explain. So we would have had patients who are accustomed coming for 3 months of medication at a time. We got to a point where we couldn't do that. We had to give them just 1 month of medication. And we had to say to them, look, I know we tell you to take this every day, but you don't need to take this every day if you're not actually having sex. And that's when we started to recommend outside of our guidelines, outside of our standard protocols, event-driven PrEP. And we only did that in a handful of cases. So I certainly can't quantify it, but I can tell you that from a practical perspective, we had no choice but to start event-driven PrEP because we had less drugs available.
Thanks very much, Anton. I don't see any other hand raised in relation to Anton's presentation. I would go to, there is Ricky Pasco. He had a question from the previous session. I will hand over the mic to Ricky for him to ask his question, and then we could briefly pass over to Giovanni for him to take us quickly through the last presentation for this training. Ricky, go ahead, please.
Well, are you hearing me?
Yes, we're hearing you.
Okay, it's kind of two questions to some extent. Another quick one for Anton. So I'm trying to figure out what if someone ended up getting HIV? Would that person continue to take PrEP, which is the oral pill, or would the system or the doctors, he or she, be switched to take a new type of ARV or another set of ARV? And if I may jump in with the other one, what are the risks that is associated with, if any, which is related to serodiscordant couples, by chance, if they decide to stop use condoms, both would be probably, the positive would be already be on meds, the other person would be on the PrEP. So what are if there's any, what are the risks that is associated with it? If those meds that they're on will stop work, or they possibly develop resistance to some extent. And if I may quickly squeeze in the one for Anton, the general thing, wanted to find out if it's the government in Barbados that is purchasing PrEP, or is it donor funding? Because I know here in Jamaica we start a pilot, but it's donor funding, not necessarily government to some extent.
Yeah, so if a person became HIV positive, the question is, why did they become HIV positive, and at what point did they become HIV positive? Pardon?
No, if they become HIV positive, let's say the person who is on PrEP becomes HIV, and end up becoming HIV positive.
Right.
But that they were started on PrEP, but eventually become positive. Will their meds be switched, or they will be?
I got your question. Sorry.
Okay.
So when I said the question is, we have to look at the different scenarios.
Okay.
So
okay.
You have a situation, it's highly unlikely, but you may have a situation where a person is on PrEP, meaning that they're on Truvada, or just 2 drugs, when in fact it should be 3. So
Right.
One of the things that we do at the start of a person being HIV positive is we take a sample for drug resistance testing. So you can use the results of that to determine what you should put the person on. I don't have any experience in terms of this, because we did have one person who became HIV positive, but they weren't on medication. What we did for that person is we started them on a regimen that included the drug that he was taking for PrEP, but we didn't have any fears that there was any resistance to those drugs. And in case there was, we have alternatives. So we switched them to what is our first line regimen, and our first-line regimen includes the Truvada component, which is 2 drugs, and you have to add a 3rd drug, right?
Okay.
Is that clear?
Yes, it is. Yes, yes, yes.
Right. So then the last question you asked was about the funding. The funding is government. So the vast majority of what we do is funded by government, but a significant portion of what we have been doing is or was supported by donors, in particular PEPFAR. So even with that small proportion supported by PEPFAR, it's going to be very difficult for me to get back the additional staff that I had supporting the STI clinic, for instance, which was significant in terms of our capacity to continue PrEP, especially because of COVID. So we already resource restricted, and COVID has just made it even harder for me to be able to get the resources that I need. Not necessarily impossible, but significantly harder. So to answer the question, government funding, as opposed to don't for the PrEP program specifically.
Okay.
So you also gave a scenario about a serodiscordant couple. So if in a serodiscordant relationship where one partner is HIV positive, the other is negative, they're using condoms, but then they stop using condoms because the positive person is on therapy.
Right.
In the scenario where the therapy is effective and the viral load is undetectable, it is highly unlikely, extremely unlikely that there will be transmission, assuming that they're mutually monogamous. And the person is adherent to their regimen.
Well, I wasn't necessarily talking about that. I was trying to figure out if any of them would have developed resistance at some point because of the fact that they started having unprotected sex.
No, the resistance is not a function of using protection.
Okay.
The resistance would be a function of being on therapy and say the person who's on therapy not taking the therapy adequately.
Okay.
Right? You can get somebody who is 100% adherent or adequately adherent to therapy and developing resistance, but the likelihood of that is so low, especially if that person has become virally suppressed and have been virally suppressed for a while. It's highly unlikely that that person will then become resistant to the therapy that they're on.
Okay.
But once again, it's important to counsel both partners and to continue clinical monitoring and laboratory monitoring of the person who's HIV positive.
Thanks for that.
Okay.
All right.
Thank you.
Thanks very much, Anton, for the clarification and the explanation given, and once again for agreeing to do this presentation to share with the wider Caribbean your experience. I know it is 5 minutes after 1, and if you would indulge us for a couple minutes, where we would ask Giovanni to just briefly go through his presentation, the main areas, and then we will share with you the presentation so you would have it as a resource material and to actually look through more at a more in-depth. So, and Giovanni, feel free to go ahead right now.
Okay, thank you so much, Sandra, and thanks everyone for your participation and patience. And Anton, because as usual, he provided a very clear overview of how a PrEP program can be implemented in an integrated way and with multiple service delivery models. So I will just go through this presentation very quickly because we can share the slides and most of the information actually refers to the PrEP implementation tool that WHO released in 2017, and there are updates and some the only module that is still pending is the one about regulatory officials. So when approaching PrEP planning, you may look at the module 9, which is about strategic planning. which is kind of a step-by-step approach to understanding which populations and which areas in your countries should be targeted for PrEP, prioritizing high-risk individuals and defining a procedure to phase in PrEP from a health system perspective. So first of all, understanding from available prevalence, incidence data, and behavioral data, as you have seen for Barbados, which populations should be targeted in your context. And there are some tools that can also be made available from PAHO to estimate what the target demand for PrEP could be in your setting. And this is how the PrEP tool looks like. It's specifically for MSM, transgender person and sex workers. But as we saw, their PrEP policies should be flexible and actually enable an equitable access to PrEP for other populations and individuals at risk. It's important to make sure that PrEP is integrated in national strategic plans and strategies, that the country has PrEP guidelines and protocols, both clinical and operational, and that the drugs are registered, possibly registered for prevention, but we know that some countries are updating the registration for prevention. Other countries are using PrEP antiretrovirals for PrEP on an off-label approach, and including the ARVs for PrEP in the national essential medicine list and in their procurement plan. Luckily, in many cases, these are the same antiretrovirals that are used for treatment. So you would just need to increase the estimated need to not just use these drugs for treatment, but also for PrEP. And there might be other norms and regulations that you might want to address, like enabling norms related to task shifting and community delivery of PrEP. If you need to develop a PrEP clinical guideline, WHO documents are certainly available as a blueprint, but we also developed a PrEP nPEP generic guideline that is available for countries to facilitate the adaptation and adoption of these recommendations. PrEP delivery models, I think it's important to consider the integrated service delivery approach. It's not a standalone intervention, but rather integrated in services where you're already providing HIV, STI prevention services and sexual health. You might want to adopt multiple PrEP delivery models, as we have seen in Barbados at a health center, at a community-based center, other forms of public-private partnerships, and consider the PrEP acceptability or service delivery preference of the target populations. Clearly define the clinical routes and flows from PrEP promotion, HIV testing, linkage to PrEP services, initiation and follow-ups, and the responsibilities of the different human resource cadres involved in HIV combination prevention services, both at the facility and community level. Of course, consider all the opportunities for innovation that Yanis mentioned in the context of the pandemic, from digital health to multi-month dispensing, digital remote prescriptions, the self-testing, self-sampling for HIV, STIs, the event-driven adoption for MSM, and the expansion of community-based and peer-led services. Coming to site planning, of course, you have to consider all the different health system building blocks to make sure that the staff is trained and there's adequate linkage to the supply chain for medicines and the linkage to the necessary lab services, but also as we're providing a comprehensive package of HIV combination prevention services, expanding to STIs and viral hepatitis, access to vaccinations is also important. And another important element for implementation is the community engagement and demand generation. The whole strategy of information, education, communication is part of increasing awareness, and by increasing awareness, increasing demand. And of course, the community should be an active partner from the beginning in both the design of service delivery models as well as communication strategies. And this should also address stigma and discrimination, because it's been reported in many cases about stigma and discrimination related to PrEP use. Stigma and discrimination are associated with being identified as a high risk individual, which actually should be turned from another perspective of being responsible about our own sexual health, and not necessarily because of the high risk definition. And lastly, monitoring and evaluation. Anton presented the 4 core indicators, and the approach is really monitoring what we now call the HIV Combination Prevention Cascade, or PrEP Cascade, looking at the different steps of screening and diagnosis and linkage to service, prevention service, being retained or continuing in prevention services. And as an outcome for persons with HIV, we have vital suppression, but for HIV negative individuals, the final outcome is remain negative over time. There's a specific module with 4 core indicators that look at PrEP uptake, continuation in PrEP, service, serious adverse events, and HIV incidence. But it's always important to look at the demographic and risk profile of PrEP users, so that we're sure that we're really targeting the right population at higher risk and at higher vulnerability. STI monitoring is important because of the concerns related to possible increase in STIs, but also other qualitative assessments about reasons for stopping or preferences for dosing or behavior change. But I think one consideration looking at the results from Barbados, it is important to understand the reasons for stopping, because they're not necessarily a performance assessment of our program. Many people may change their profile or their preference related to which prevention tools are using. Many serodiscordant couple might stop because of viral suppression. So not all PrEP interruptions are, let's say, should be considered as a negative performance. And finally, this is a tool from PAHO for the monitoring of HIV prevention services and the PrEP Cascade that is available for all countries and services that are interested in implementing PrEP, HIV combination prevention, and measuring their results. And thank you very much. Again, all the information that I presented can be found on the WHO website in the different modules of the PrEP implementation tool. Thank you.
Thanks very much, Giovanni, for the overview of the programming of PrEP at country level. The take-home message was at least one emphasized throughout the webinar, in which PrEP is not a standalone service, but is offered within the HIV combination prevention package of services. And of course, the services should be integrated, and there's need to have community, important to have community engagement. Lots of information were shared. We will be sharing the links. There are links of some of the documentation. I think Timothy will be putting those up shortly links to some of the documents. We will also be sharing them when the presentations are shared. And also, as Giovanni mentioned, these documents are also on the PAHO, WHO and on the WHO website, and we will also be making them available on the PAHO website for the Caribbean. I know we have, thanks very much for indulging us to go at least over the time established. It's now 1:15. We're coming to a close. I know that Trishana Barkley has a question. She's the only person with her hands up. I'm wondering if you have a question, if you could, or comment, if we could make it short so that Giovanni can respond just before we close. Trishana? I'm not certain if she was on. I don't see her anymore, so she perhaps have left. Is she on? No, she's on. Timothy? Okay. I guess we perhaps lost that question, but please feel free to send us an email if you have any questions or clarifications that you would want for any of the panelists to respond to. So we come to the end of this training session. It's always seemed like we never have enough time for the question and answer session, but I thank you very much for allowing us to go beyond the time that was allotted for this session. On behalf of PAHO and PANCAP, thank you for your participation. At PAHO, we look forward to supporting countries to advance the implementation of PrEP or to continue to strengthen the implementation of PrEP. For countries that are interested in advancing to PrEP, those that are not under the current Global Fund grant, please feel free to contact us through the PAHO local office, the country office, if you desire technical support to actually advance or to implement PrEP and PEP at the country level, or whatever technical support you may require as it relates to HIV, STI, viral hepatitis, and TB. Once again, thanks for your ongoing support. We have another training plan under this, under the PANCAP, PAHO PANCAP CVC COIN Global Fund grant. This next training is scheduled for October, and it will look at the monitoring of HIV STI services within for key population. I know Giovanni spoke about it just a while ago, but we hope to have an additional training that will look at this aspect more broadly. So thank you very much once again for your participation, for staying with us until the end, and the presentations and the different links to the guidelines as it relates to PrEP and nPEP will be shared. Thank you very much. This brings us to the end of this webinar. I don't know if Rosman, do you want to say something just before we close?
Thank you, Sandra. Let me, I know that we're way over time, so I'll just like to say thanks to all of the presenters. Indeed, as you said, it always appears if we don't have enough time, and it really speaks to the type of content and the type of presentations that we have and the details in which we have to present, and also the engagement in terms of the questions that the participants have raised. But this is really an issue that we have to continue to work on, and I like the way in which the presentations did show that PrEP in itself is not done in isolation, but is part of the comprehensive combination prevention approach. So We will continue to keep national programs, civil society engaged as we try to see how best we can look towards implementation where countries are thinking of implementing, and those countries that have implemented, how we can scale up in terms of listening to Dr. Best's presentation, how best we can support these gaps and challenges to ensure that that these programs are scale up. So in the interest of time, I'll end here, Sandra, and I'll say thanks to everyone again for participating, the presenters and the participants. And thanks to you.
Okay, thank you very much, Dr. Adams. And yes, thanks to my colleagues, Giovanni, Yanis, and Dr. Best. Thank you very much for your usual cooperation and support. Thanks to all our participants. We see you at the next training. Thank you. Have a wonderful day.